A few more people will be jumping on as we're speaking, but I'm going to start by introducing Dr. Jenny Chen. Thank you so much for being here with us today. She is currently finishing up her second year fellowship in neurotology at Johns Hopkins. Dr. Chen completed her undergraduate training in human development and regenerative biology at Harvard, where she also went on to complete her medical degree and her residency in otolaryngology, head and neck surgery. She then joined the staff at Mass Eye and Ear as an attending for a year, and she also completed her master's in education at Harvard during that time, before joining the neurotology program at Johns Hopkins and becoming their fellow. And then she's also going to be joining their faculty come this summer, so very exciting. Among Dr. Chen's many accolades, she's received a number of awards, including a core grant from the AAO, an endowment grant from the Women in Otolaryngology section of the Academy, and a Digital Education and Learning Technology Acceleration Grant, or DELTA grant award from Johns Hopkins. Dr. Chen's research focuses on innovations in medical education and surgical education, and in particular, her work is focused on competency-based, outcomes-focused approaches to surgical education. And today she'll be speaking to us about her talk entitled Competency-Based Medical Education in Otology and Neurotology. So thank you so much for being here, Dr. Chen, and look forward to your talk.
Great. Thank you so much for joining. I know Monday evenings, there's lots of stuff to be done, M&Ms, catching up on notes. I'm hopeful that this is a topic that is interesting to a lot of people, mostly because we are all really invested, I think, if not only in our own trainings, but in the training of others. And there's really a lot of research going on in and outside of otolaryngology that I think the subspecialists are not always very familiar with. So as a fellow in otology, neurotology, sometimes I think about, what is our unique perspective on this? What is our unique perspective on training challenges in ENT? And so I'm really excited to put together this talk because I think it gives me an opportunity to think about, why do I do research on competency-based medical education, and how could that inform, aspects of teaching in otology, neurotology, aspects of policy making that we as subspecialists help our societies and like the ACGME and our review committees make a lot of important decisions about, and what kind of tools are, what kind of research is available out there for us to reference. So let's see. To advance my slides. Is that a thing? Oh, here we go. Okay. All right. So at the end of the session, I'm hopeful just that we'll be able to cover just the following 3 questions, right? So going from the very basics, what is competency-based medical education? Many of us may not have even heard of this before, although it's quite a buzzword, I think, in graduate medical education training now. Secondly, why does it matter for otology, neurotology, right? We're a very small subspecialty. We graduate less than 20 subspecialists a year, and certainly there are more practicing general otology out there, but as you'll see, maybe less and less in recent years. And thirdly, what research is being done to inform the implementation of competency-based medical training in our specialty, and perhaps even within our subspecialty? So taking a step back again, competency-based medical education has really become, I think, a buzzword because I see it written a lot when people are talking about pretty much anything education related in medical education and surgical education these days, right? So some people use it to refer to things like simulation or curriculum adjuncts or assessments. And so I just want to start with like a really broad definition of it. And this is one person's definition of it, and it's that it's an outcomes-based approach, so we have to have outcomes, to the design and implementation, assessment and evaluation of medical education programs using an organizing framework of competencies, right? So what sets this apart from really putting together any design of like a curriculum to train someone to become a medical professional is that it's centered on outcomes and it's centered on frameworks of competencies. Those are the things that stand out to me, right? So it's very deliberate in the way that it theoretically approaches the design, implementation, assessment, evaluation, and it has a major focus on measurable outcomes, right? So the measurable outcomes approach is something I'm very interested in because, of course, it lends itself to research and it lends itself to evidence-based decision-making, which I think is something that's been difficult in all scopes of education and definitely medical education. So one of the first things that people ask is, we've been training doctors for decades, not centuries, since the Flexner report. So why does graduate medical education need competency-based medical training, right? And so Eric Humbo, who used to be the research director at the ACGME, writes that, people will ask, are physicians being adequately prepared for 21st century practice, right? And his opinion as an expert in the field is that multiple reports have concluded that the answer is no. Right. And this is because in the past decade, maybe even over the last 50 years, modern medical practice has really dramatically changed. We're no longer focused on the individual decisions because team-based care is so much more important. We're also in the midst of rapidly evolving practices, whether that's research on medicines or research on what standard of practice or technology, right? A number of technologies that didn't exist 20 years ago are common practice in otolaryngology these days, whether it's devices or robotics or even the way that we use endoscopes. We're also much more focused on quality reforms, right? So understanding how to deliver a higher quality care across populations, and then at the same time focused on patient-centered care. So these are challenges of modern medical practice that make it more and more difficult to train people within a certain period of time, right? The period of time hasn't really changed over the past 50 years. And then more specifically, why does graduate surgical training need competency-based medical education? And this is, people argue that we are moving from an older model, the Hallstadian model, where residents were supposed to see one, do one, and then teach one in sort of rapid succession. There was limited supervision and much more significant autonomy, for better or for worse. This was a time spent model, right? So residents would live in the hospitals for a certain number of years, and presumably they would osmose, within the environment, these experiences, and then graduate at a certain number of years. And so there was less emphasis on the quality of teachers and experiences. We're now moving towards a new model that's hopefully a competency-based model. And this is perhaps because we're moving into training with more supervision. Residents and trainees at all levels are struggling with issues of reduced autonomy because we need to ensure a certain quality of care for patients. And additionally, procedures are just getting harder, right? There are more procedures. We know that there exist more procedures in every specialty, including otolaryngology. And so because of this, we have to be more careful of how we're practicing, right? So this new idea of deliberate practice, making every repetition count, getting a lot of feedback for every repetition, and having the type of supervision that emphasizes the quality of teachers and experiences. Within this new model comes questions about whether we might be able to one day vary the length and the structures of training, right? So if you're really creating a competency-based model, if I can become competent at one procedure in a shorter amount of time than what's average, but it takes me longer to become competent in a second one, shouldn't I spend more time doing the second one, right? That would be the ideal scenario. However, as we shift from the old model to the new model, the problem is, what are we going to use to assess the competency, right? We're becoming more and more interested in the outcomes. So what are these outcomes we're actually measuring? So these are the outcomes we currently have. We have case numbers, right? Everybody logs case numbers on the ACGME websites. That's a requirement. And we also, for residency, have things called key indicator procedures. So as many of you know, there were 14 for otolaryngology residents, 3 of which are centered on otology procedures. That's mastoidectomy, tympanoplasty, and ossiculoplasty. Those are the 3. But what we actually want is we want to track and predict operative performance, right? Like ideally, we would have maybe down to the level of all of the surgical video of every procedure you performed as a senior resident. So we can figure out what that looks like, or some kind of longitudinal assessment, or some kind of more detail than just, I did a surgery, right? Because we all know that doing the surgery as a trainee can mean many different things, right? We could have a significant amount of autonomy, or the attending is in the room and watching every single move, or actually doing the critical portions. So that range is not captured by what we currently have. And so as we're thinking about how competency-based medical education is becoming more important and commonplace for training, even in the United States, I do want to talk about how this type of granular detailed assessments could be integrated in our current training, right? So let's think about what our current training already does. So competency-based medical education actually is not new for any of us, because it was built in as a component of the ACGME core competencies, right? So you may have heard that we have 6 core competencies, 2 of which are the most, front of mind here, ones like patient care and medical knowledge. These are ones that we think are like relatively easy to assess. And then there's also things like system-based practice, professionalism, et cetera. This is already something that's ingrained into the way that our residency programs are developed, because the ACGME requires some measurements and coverage of the core competencies. Many of you may also have been assessed on milestones in residency, right? So your program director may have shown you your milestones in your biannual reviews, and some of you may have had to do self-assessments for these. And so in the latest iteration of the milestones, these are 3 of the example milestones, right? So these become slightly more granular than just patient care and medical knowledge. So under patient care, there might be like head and neck neoplasms. That's a milestone. And you get a rating from 1 to 5, where 5 is like the aspirational and totally independent rating where you're managing complications. And 1 is like that intern or pre-intern level where you're just describing very basic anatomy and understanding of the disease. Another milestone is anatomy in general. Another different one is pathophysiology, right? But as you can see, it can be hard to, from a program director and even as a teacher's perspective, to evaluate people on these. So although all of your clinical competency committees have evaluated all of you on these at some point in time, you can imagine it's actually a difficult thing to do, right? Like, how do I know what Josh's mastery of anatomy actually is, like the whole of anatomy? So a new thing that's been developed are these like micro assessments, these ideas of like these granular, much more granular assessments of procedural performance and other types of performance, right? So instead of directly evaluating someone on like head and neck neoplasm or anatomy or pathophysiology, maybe be easier to just measure their performance of an uncomplicated parotid surgery, right? So if you can give them a rating of this, and we could track the rating of their parotid surgery performance over time, we can use this to inform the assessments of milestones, and then indirectly inform the assessments of core competencies, right? So this is an example of framework that's being built out with the support of the ACGME. For all different types of micro assessments, whether it's of procedural skills in surgical specialties or in cognitive skills in non-procedure based specialties. I do want to mention this because outside of otolaryngology and also outside of the United States, there's significant progress being made in this type of narrowing down the types of assessments to the level of granularity you might need for truly competency-based training. Okay, so this is a timeline of just some of the key events. So I mentioned since 1999, the ACGME has had the core competencies that all of the residency programs have to adhere to. And then 2008, the Netherlands implemented their own full version of competency-based medical education. And actually, they've used micro assessments and have been successful across multiple specialties in implementing time variable training, which is very interesting. In 2013, the ACGME launched milestones, which they consider the first step towards granularity in the outcomes measurements, as we saw in the previous slide. And in 2017, Canada actually came out of nowhere and implemented their own entire framework, a little bit similar to the Netherlands, using micro assessments, again, to track longitudinally their outcomes. Otolaryngology, interestingly, was actually the first specialty in Canada to be converted. In 2018, general surgery in the United States launched their microassessment, also known in some literature as an entrustable professional activity, but we won't go into that detailed definition of that. But they launched their microassessment pilot in 2018. And then pediatrics launched in 2020. And then there's been really large grants given out by groups like the AMA since then to study competency-based medical education in fields like emergency medicine. Most notably, last year, the American Board of General Surgery launched their microassessments as a requirement for board certification, right? So this is across like hundreds of general surgery programs. All the interns will need to submit microassessments just to sit for their boards in the future. And so this is sort of like an overview of where this movement is going. And I thought this would be interesting to think about, because I think as an otologist, neurotologist, as I'm practicing, sometimes I think that I feel like we're very far removed from the type of research I'm interested in competency-based training. But in my mind, when someone asks me why people in our specialty or our subspecialty should care about competency-based training, I think it's fundamentally because ear surgery is really hard. Right. And I actually, this is not just because, you're my audience here, and I think many of you would agree, but, we actually have data to show that this is the case. And so, for example, I think 4 or 5 years ago, I surveyed program directors across the United States, asking them how comfortable their graduating residents, right, within their last 2 months of residency, how comfortable are they performing each of the 14 key indicator procedures? So I mentioned there's 14 key indicator procedures spanning all of otolaryngology. And here I actually list only the 4 most difficult procedures based on program directors' survey responses. And you can see that all 3 of the otology procedures rank among the top 5. Okay, so program directors think otology procedures are really hard, right? The hardest among which are the stapedectomy/ossiculoplasty procedures. You'll see that about 15% think that their graduating residents are uncomfortable performing ossiculoplasty and stapedectomy. And then something around 7 to 8% are uncomfortable performing tympanoplasty and mastoidectomy, right? So they're saying that basically all the residents from these program directors' programs are not comfortable performing it. Interestingly, though, the residents feel even worse. So we surveyed recent graduates who graduated within the past, I believe it was 8 years, how comfortable they are performing the same 14 procedures. And again, the 3 otology procedures are among the most difficult. These are the top 4 most difficult procedures. And here it's actually even worse, right? So more than 50% of recent graduates are at least somewhat uncomfortable performing ossiculoplasty. 25% are uncomfortable performing mastoidectomy, right? Which we consider probably a critical skill for anyone taking call. And then over 20% are even uncomfortable performing tympanoplasty, right? So these are the hardest procedures in our specialty, at least across the key indicator procedures. And so it is important as otologists and neurotologists to think about why competency-based training is important, because these are the procedures that, we have found to be the most difficult to teach and to learn. Right. What are some other problems specific to otology and neurotology? Many of you may know that there was this number of studies a couple of years ago by our colleagues in otology and neurotology about who is performing stapes surgery. And so Michael Ruckenstein in this survey of 180 general otolaryngologists in his local area found that actually, and reading from the bottom of the sentence, 90% of graduates who graduated in the 2000s never performed stapedectomy as part of their practices, right? And then among those who graduated in the 1990s, 50% never performed stapedectomy as part of their practices. Those who graduated in the 1980s and 1970s were much more likely to perform stapedectomy as part of their practice. Right? So you can have many different interpretations of this. And then some of their colleagues did a follow-up study thinking about why this might be, right? Like, why are recent graduates not as comfortable performing stapedectomy? And for them, they really looked at demographic data and found that the incidence of surgically confirmed cases of otosclerosis has declined nearly 85% since the 1970s, right? So this could be a reason for why residents are no longer feeling very confident. Current trends suggest that otolaryngology residents will participate in only 8 stapedectomies throughout their training, and the small number of cases nationally supports removing stapedectomy as an ACGME key indicator case for otolaryngology residents. And actually, in fact, in 2019, which is just the year prior to when this was published, the ACGME review committee did decide to change the name of the key indicator procedure from stapedectomy/osticuloplasty to just osticular chain surgery. Right, so you can log stapedectomies as part of that, but you don't actually have to do any stapedectomies to meet your key indicator procedure numbers. And this is an interesting study that was just published earlier this year by some of our colleagues, looking at modern trends in otologic training and implications for residency training. Right, so they looked at analysis of DoD beneficiaries from 2010 to 2019 and showed steady declines in osticuloplasty. So not just stapedectomy, but now also osticuloplasty is also challenging. If these trends continue, more cochlear implantations may be performed annually than stapedectomy and osticuloplasty combined. These changes in surgical volume have direct implication on resident education. Right. So knowing that there are all of these trends in our patient population, and therefore trends in our training, what should we do now and in the future about how we train people to become otologists and neurotologists, right? I think that this is what makes competency-based medical education research so fascinating for people invested in our subspecialty, because we have a lot of unanswered questions, right? Like, for example, if residents perform 8 stapedectomies, is that enough? How do we know it's enough? You know, maybe it is enough. Maybe they're going in there doing those 8 stapedectomies almost independently, and they're becoming very proficient. We just don't have the data. And so this moves us to our final question I want to cover this evening, which is what research is being done to inform the implementation of competency-based medical education in our specialty. And for this, I am going to talk primarily about my own research, although there's really excellent research being done at many different centers in and out of otolaryngology. So I'm going to talk about both quantitative research on procedural competencies, as well as a little bit at the end on qualitative research on how CBME is implemented and used. So my quantitative research is predominantly conducted when I was a resident through a couple of funded grants through the academy, looking at something called SIMPLE. So this is the System for Improving and Measuring Procedural Learning in the OR. And essentially what this is just a very small app on the phone, which takes about 30 seconds to complete after a surgical procedure. So a resident will do a case, say they do a mastoidectomy with me, and then the resident or I will log the case into the system with my name, their name, the date of the procedure, and then what surgery we did. After that, it asks both myself and the resident, you know, what was the resident's autonomy? What's the level of autonomy? What's their level of performance? And how complicated is this case relative to, you know, all-comer mastoidectomies? And then at the end, I can dictate feedback for the resident, and then the resident can actually push this case to their ACGME case logs. So it takes only about 30 seconds, maybe a minute, including dictations, to do this. And as you can see, this is an example of a way to deliver a micro assessment that might be necessary to deliver to develop the granularity that we would need to track and make decisions about how to structure a competency-based training. So we're just going to go over this very briefly, but the levels of autonomy are defined on 4 levels in this app. And this is based on, you know, significant prior research that validates these scales. So the first level is show and tell, where the attending's doing the majority of the key portions. Second level is the attending is giving active help for at least 50% of the key portions of the case. Third level is passive help, where the attending is following for key portions, and the resident is starting to lead, essentially. And the last level is supervision only, where the resident is mimicking independence, and the attending gives no unsolicited advice for the majority of key portions of the case. The surgical performance scale is something a little similar to the milestones ratings, right? Where 1 isn't, it goes from 1 to 5, where 4 is actually practice ready. So 4 is actually what we're aiming for by graduation, and 5 is really exceptional performance. And last question I mentioned is case complexity, really considering patient factors, nothing to do with, the resident or the attending in the case. Was this the hard mastoid? Was it, very cue ball mastoid? Was there sigmoid sinus dehiscence? All these other things, just to give some context to the case. And so one of the earlier studies we ran was a multi-institutional study of key indicator procedures, those 14 key indicator procedures for residents at 5 different otolaryngology training programs. And these are all large programs. So I've picked out some of our findings, and I've marked off with little ears the ones that pertain to otology and neurotology. So on the left-hand side, what I'm graphing is the cases with meaningful autonomy by the time the residents are in PGY4 and PGY5, right? So that you can see that for the first little ear icon, tympanoplasties, I would say 70+% of residents are getting meaningful autonomy in tympanoplasty cases at senior residents. For mastoidectomy, it's around 60%, but then for stapes and aciculoplasty, it's around 30-something%. Right. And then similarly on the right-hand side, what I'm graphing is cases rated practice ready, right? So the attending did the case with the resident and the attending was like, you did a great job. You are practice ready as a PGY4 or PGY5 resident. So for tympanoplasty, you can see again, it's about 75% of cases are done at that level for senior residents. For mastoidectomy, it's about 50. And then for stapes and aciculoplasty, it's about 30s. So knowing this, just benchmarking, I think is not enough. What we're actually interested in knowing is once a resident comes to you, not only do you want to know where they land in terms of comparing across their peers, but I also would love to know what their prior performance means in terms of future predictions, right? So if they show me a certain number of cases that they've logged practice ready or they've logged with meaningful autonomy, how do I know in the future what their performance is going to be like? Luckily, there is a way to predict this, right? So what I'm thinking about is how can I tell based on a resident's prior practice ready ratings, can I put them into a model so that I can make predictions about whether they are going to be quote unquote competent when they're independent? And so this work I did with a learning analytics PhD based out of the University of Michigan. And essentially, to simplify it, what we did is create a variable to track the pattern of practice ready ratings. Okay. And then we modeled the number of prior practice ready ratings needed at each PGY level to predict with 95% confidence that the next rating will also be practice ready. Okay. So this is an interesting idea because I mentioned before that what we have are case numbers, right? And even if you have case numbers, you still can't tell what that's going to predict of in the future, right? Is 8 stapedectomies for each resident enough? Well, with this, we might be able to actually answer this type of question because it's a question of within those 8 stapedectomies, how many of them were practice ready? And what does that mean about predicting future performance for this training? And so this is what our predicted probability curves look like. Starting on the left-hand side, you can see that for a PGY3 resident in our study, if they show you 13 practice-ready ratings, so on the x-axis, there's probably a 95% chance that their next one will also be practice-ready, right? That's a lot. If I saw a PGY3 that could do 13 practice-ready mastoidectomies, I'm probably pretty confident that the next one will also be practice-ready. Interestingly, on the right-hand side for PGY5 resident, they only need to show you 4. And I think that intuitively does make sense, right? You meet a chief resident, they show you a really well-done mastoidectomy. And the next one, you're already inherently more likely to trust them. And this is what the system says is probably correct, right? They only need you to show you 4 practice-ready ratings in order to predict with 95% confidence that their next one will also be practice-ready. What that allows us to do is look across key indicator procedures. So here for the first time, I listed all 14 just to not be distracting, but I have highlighted the 3 otology ones. And you can see that, for example, on the most right-hand side, for PGY5 resident, they need to show you 4 mastoidectomies at practice-ready level, 5 ossicular chain surgeries at practice-ready level, and then 4 tympanoplasties at practice-ready level in order for this model to predict that their next following one will also be practice-ready. This gives us really interesting ways of benchmarking what our residents have done, and gives us a way of making models about when they have achieved that plateau level of competency, right? Where they're just the next ones are all going to be practice ready, which is what we really hope for graduating residents. So just a general summary of the quantitative research findings. We show that microassessments with mobile apps can be used efficiently to benchmark and longitudinally track procedural competencies, and that predictive modeling can be used to inform assessment benchmarks for competency-based training in otolaryngology and within our subspecialty. And perhaps it's quite important within our subspecialty because there are all these questions about how, procedure numbers are dwindling and our procedures are just harder, among the hardest in ENT. So my future research is quantitatively focused on looking at how we can identify procedures to track the progressive development of skills, right? So how do we know that mastoidectomy and tympanoplasties are the right ones to track? And then how should we refine the list of procedures to be assessed? Because while we collect more data, we can perhaps look at relationships between, if you can do a mastoidectomy, does that actually very predictive of whether you can do a tympanoplasty, and vice versa? We just don't know the answers to these questions. So I want to switch gears a little bit now at the end, just to talk more broad level about some of the qualitative research being done on how competency-based medical education is actually used worldwide. And this is important, I think, because, as I mentioned in a previous slide, the United States is actually far behind a couple of countries in implementing competency-based medical education. And just like everything else in medicine, the implementation is as important as the idea, right? So like two different hospitals, institutions, countries can have the same idea that we might need to be more outcomes oriented in our training. And yet the way that it's carried out, what type of metrics they're going to use, what type of theory they're going to base it off of could be entirely different. And so I've had the privilege of being one of the visiting scholars for the American Board of Medical Specialties this year with a project titled Envisioning the Path to Competency-Based Medical Education for Otolaryngology and Head and Neck Surgery in the US. And so ironically, although I'm interested in figuring out how we could go about this in the US, my research is actually based out of Canada and the Netherlands. So in Canada, like I mentioned, they've had CBME for otolaryngology since 2017. And so I have been collaborating with those at the University of Toronto, meeting with their PDs, APDs, visiting them on site, shadowing them in their otology ORs, because that is obviously the most important to me, and beginning a collaboration with one of their APDs on quantitative and, more interestingly for me, qualitative studies, right? Trying to figure out whether their competency committees find those microassessments useful, whether residents find them useful, whether residents use them at all, whether program directors use them to make decisions about training, and whether it has impacted anyone's plans for remediation or thinking about moving ahead or prolonging their training. So I'm interested in that. Similarly, the Netherlands is actually even further ahead. I mentioned they've been doing this since the early 2000s. And so I'm visiting with them later this month to, again, learn more about the health system, right? Because all the implementation is done within the context of the health system, and review a lot of their materials and how they implement their microassessments within a larger national curriculum and assessments and standards. So that is still very, very early on in the research, and I don't have any data to show for that yet. But I think really interestingly, at least to understand what other countries have gone through, because they have, a decade or two of implementation ahead of us. And so going back to the goals of the session, I hope that I've been able to cover a little bit more of your understanding of what is competency-based medical education, why I think our specialty and specifically our subspecialty really will depend on competency-based medical training to make decisions and to inform both the design and the outcomes of our curriculum in the future. And lastly, a sort of a broad overview of the types of research being done to inform the implementation of competency-based medical training in our specialty. So with that, I just want to acknowledge some folks who I've collaborated with, including my mentors here at Hopkins, John Carey, the ABOHNS board, who's sponsored a lot of my research and has been very supportive, as well as my collaborators at a number of other institutions within and outside of otolaryngology. These are my funding disclosures. I talked about a little bit also already. I think Josh mentioned them earlier on. And then I'm happy to take any questions, as well as I have questions for the audience too, if there are no questions for me.
And that was a really, really excellent talk. Thank you, Dr. Chen. I have a couple questions, and I'll give other people a second, and then we will answer your questions. I was thinking as you were talking about what the role and potential bias of the evaluator, meaning the attending physician, might be here, and like how do you, like in the same way that how do you know that a resident is competent? Like what are you measuring? How do you say they are? Like how do you know that the faculty member evaluating them even knows what competency is? Assuming they do, of course, but like how do you really know that when they say this resident is practice ready that they are? And then the secondary part of the question is like when I'm thinking about your predictive model,